all. I welcome our director, CV Rao sir, Director General Dr. Nageshwar Rao sir, Principal Dr. Devesh Rao sir, Academic Convener Dr. Ishwar sir, all the HODs, faculty members, senior and junior residents, for today's program of clinical case discussion of interesting cases. So today we have a total of 4 cases for discussion from the departments of neurology, cardiology and general medicine. Cases are life-saving primary PCI from Department of Cardiology, pellagra from Department of Medicine, episodic encephalopathy from Department of Neurology, a pattern rash with predictable evolution from Department of General Medicine. First, we will start with the case episodic encephalopathy from Department of Neurology, presented by Dr. Manasvi, Department of General Medicine. The moderator, Dr. Vamsi Krishna sir and Sajna.
I am Dr. V. Manasvi, third year postgraduate from the Department of General Medicine, presenting the case from Department of Neurology. Episodic encephalopathy. Chief complaints: a 51-year-old woman presented with complaint of one episode of involuntary movements of all 4 limbs for about 5 minutes 4 days back. Complaint of altered sensorium since 4 days. History of present illness: patient was apparently normal 4 days back, after which he had an episode of involuntary movements of all 4 limbs with uprolling of eyes and frothing from mouth for about 5 minutes, followed by altered sensorium since then. No history of any fever or headache prior to this episode. No complaint of shortness of breath, chest pain, palpitations. No complaint of abdominal pain, loose stools, vomitings, yellowish discoloration of eyes. No complaint of cough, cold or wheeze. No complaint of burning micturition, increased or decreased frequency of micturition. Past history: she had a history of recurrent episodes of altered sensorium, 1 to 2 episodes per year for about 2 years. Every time she was drowsy, arousable for almost a week, for which she was admitted in various hospitals. She is not a known case of type 2 diabetes, hypertension, CAD, CVA, CKD, bronchial asthma or thyroid disease. No previous surgeries or blood transfusions. Family history: she has no similar complaints in the family. Menstrual and obstetric history: menopause attained 5 years ago. Previous cycles were regular. She gave birth to 2 healthy children. No history of abortions. Personal history: she takes mixed diet. She has normal appetite, normal sleep, normal bowel and bladder habits. On general examination at the time of presentation, patient was unconscious. GCS 3/15, BP 130/80 mmHg, pulse rate 95 beats per minute, respiratory rate 19 cycles per minute, saturation was 97% on room air, temperature febrile, GRBS 100. On examination, there is no paler icterus cyanosis, clubbing, lymphadenopathy or pedal edema. Systemic examination: cardiovascular system S1, S2 heard, no murmurs. Respiratory system bilateral, normal vesicular breath sounds heard, no added sounds. Per abdomen soft, no organomegaly. CNS examination: GCS 3/15, MMSC could not be assessed, pupils bilateral, equal in size, reacting to light. Motor system examination: bulk equal on both sides, reflexes bilateral mute. Provisional diagnosis: episodic encephalopathy under evaluation. Query: non-convulsive status epilepticus. Secondary to query: autoimmune encephalitis. Query: encephalopathy. Outside investigations showed CBP normal, serum electrolytes.
She had unconsciousness. How many long years?
For 2 years, sir. Every time for.
What the duration tells you in your differential diagnosis? Go back. Your written that is an autoimmune encephalitis and encephalopathy. Will it be tenable for 2 years of long duration with repeated episodes? An autoimmune encephalitis presenting with an unconsciousness to recover 2 times within a short span of time without much treatment and to recur 2 years is an unlikely phenomenon to consider at all by time duration and recurrence. Therefore, the differential diagnosis is either one of the two under evaluation 2 is a non-convulsive status, but not the autoimmune component. That point with the history. But episodic unconsciousness is quite common of recurrent nature in a pediatric case groups, particularly with reference to ammonic inborn errors of ammonia citrulline cycles. But she is an adult having 2 children. Therefore, when she has got the pregnancy, all the citrulline group of ammonic cycle, that is urea citrulline cycle, congenital anomalies are excluded in born errors. First one is episodic encephalopathy under evaluation, whether it is metabolic or otherwise, non-convulsive status.
MRI prep.
These are MRI films done outside the hospital showing the presence of increased signal intensity in T1 rated images in globus pallidus suggesting macular deposition. These are T2 images showing hyperintense signals along the long cortical tracts of corona radiator. We can see hyperintense signal intensities in globus pallidus, putamen, insular cortex, and medial temporal lobes also.
Report was given as normal. No evidence of acute infarct or hematoma in the present scan. No evidence of abnormally enhancing lesion in the present scan. EEG, which was done outside, revealed abnormal EEG record suggestive of generalized epileptiform discharges.
Mentioned there, epileptiform discharges are many times like your PQRS waves, or their spike or dome or sharp waves or something else. Epileptiform discharges means there are abnormal action potentials. You have to mention the nature of action potentials in ECG. What are their abnormal? Is a spike and dome, or a only big waves, a sharp waves, or otherwise small waves, or otherwise no waves, or something like that.
CSF analysis was done outside, which was normal. LFTs done outside revealed mild elevation in enzymes. Ultrasound abdomen and pelvis done outside revealed no significant abnormality. Autoimmune encephalitis panel was done outside, which was completely negative. Investigations at the time of admission into our hospital revealed elevation in total WBC counts. Serum electrolytes revealed hypokalemia. RFTs were normal. LFTs revealed 3 to 4 times elevation in SGOT and SGPT with increase in alkaline phosphatase. PT is mildly elevated. Virals are negative. TSH was normal. ECG, this is a 12-lead standardized ECG showing sinus tachycardia with LVH. 2D echo revealed mild concentric LVH with no RWMA, grade 1 LVDD, trivial MR, TR, no PAH, no clots, vegetations or PE. Chest X-ray.
This is a frontal chest radiogram with trachea in midline. Apparent cardiomegaly may be due to patient lying down position. Bilateral lung films appear clear up to the visualized extent. Postophrenic angles appear free. Both domes of diaphragm are well outlined.
Ultrasound abdomen and pelvis was done bedside, revealed no significant abnormality. A patient was intubated in view of poor GCS. Treatment at the time of admission, She was given IV fluids and injection ceftriaxone 2 gram IV 12th hourly was given in view of encephalitis. Injection Levipil 500 mg IV 8th hourly with clobazam 10 mg 24th hourly was given along with multivitamins. Day 1 to 3, vitals was stable with saturation 98% with 35% FiO2. GCS was E1VT M2 and injection clindamycin 600 mg 12th hourly was added in view of aspiration pneumonia. These are the serial LFTs done in our hospital. They revealed at the time of admission and on day 3 there is 3 to 4 times elevation in SGOT and SGPT, and by 10 they almost became normal. Day 3, serum ammonia was sent to rule out hepatic encephalopathy. It was elevated. Gastroenterology opinion was taken in view of deranged LFTs. Sir advised serum ceruloplasmin and 24-hour urine copper with fibroscan. Serum ceruloplasmin was normal. Ophthalmology opinion was taken. Revealed no KF rings with normal fundus examination. MRI brain.
These are MRI axial images of brain. This is brain sequence and this is T2 sequence showing hyperintense signal along the corticospinal tracts and coronary artery. Hyperintense signals are also seen in globus pallidus, putamen, cardiac nucleus, this is insula cortex. They are also seen in medial temporal lobes also, suggesting acute and chronic hepatic encephalopathy. There is a hyperintense signal intensity seen in E1 sequence of brain also. This is the globus pallidus showing hyperintense signal intensity.
MRI brain report. Subtle T2 weighted images or diffusion weighted image signal changes seen in cerebellum, temporal lobes, deep gray nuclei and long tracts in coronary radiata, bilaterally symmetrical on T1 weighted image. Imaging features are more in favor of acute or chronic hepatic encephalopathy related changes, hyperammonic encephalopathy. Day 4 to 9, her GCS improved from 3/15 to 15/15 within these 5 days. Vitals were normal. She was extubated. Ultrasound abdomen and pelvis. Repeat ultrasound revealed liver showing mildly coarse echo texture to rule out chronic liver disease. Liver shows fatty infiltration with areas of fatty sparing in segment 5 of right lobe of liver. Portal vein is attenuated in caliber with mild color uptake, and few peripancreatitis collateral vessels could be chronic thrombus or extrahepatic portal vein obstruction. CECT abdomen and pelvis.
No, before that ultrasound. You like to comment on the ultrasound? You have written the last para. Any difficult component? Where the portal vein is not seen in excess thrombosis with the peripancreatic and other collateral vein, call it the portal cavernoma on the secondary to portal. Am I right, sir? Tissue of vessels, primary portal vein is blocked. Next, CT.
These are curved reformatted CECT abdomen and pelvis images showing this is a superior mesenteric vein and splenic vein which is combining to form the portal vein. The portal vein here at the porta hepatis is attenuated in caliber, which could be due to thrombosis. The thrombosis is also seen extending into the superior mesenteric vein, which is seen as a filling defect. We can see here the presence of collaterals which are dilated and tortuous in peripancreatic and periportal areas. Here we can see this is the IVC and this is the left renal vein and right renal vein is seen the IVC. In this image, we can see the collateral from portal vein which is dilated and tortuous is seen joining the systemic vein, that is left renal vein. This is the portosystemic shunt.
CACT abdomen and pelvis, portal vein is severely attenuated in caliber with a few pancreatic and periportal collaterals, possibility of a chronic thrombus.
The question is, your ultrasound, outside ultrasound apparently normal. Can you comment anything? Why you ordered CACT? Because they are normal.
The ultrasound repeated in our hospital again showed the thrombosis.
Ultrasound is normal. Second.
First one we gave it as normal and second one.
There is a confusion of the ultrasound here. First and second reports are differential. That's what the presentation. And now what is your summary of the CACT?
Due to the presence of thrombosis and chronic liver disease, there is development of periportal and peripancreatic collaterals, forming a portosystemic shunt with left renal vein.
Arterial ammonia was sent on day 8, which was elevated. ANA profile was done, which was negative. Thrombotic profile was sent for further evaluation. There is mild elevation in lupus anticoagulant.
Why arterial ammonia?
As it is
Hepatic encephalopathy, the primarily renal and portocaval shunting and a portal vein to the top, the systemic veins of various stadia, where in which the ammonic components will go either directly to the Watson plexus or otherwise to the circulation into the things and excites astrocytic proliferation. But it seems not like a perivascular astrocytic proliferation of the chronic cirrhotic ammonic encephalopathy. And you will understand another thing doesn't tell. Is it the primary vascular disease resulting in liver function, or is it the primary liver disease and cirrhosis resulting in portal hypertension? That's the question here. And you already had a venous ammonia about naturally. Why? You had a porto, that means leno-renal shunting is present. The moment leno-renal shunting is present, the ammonia can escape into the splenic vein from the top of the renal vein. Number one. What is the reason for arterial ammonia? I don't know. Can you make a comment on that? Because by the time ammonia comes from the venous circle to the portal vein or hepatic vein or otherwise, it will be neutralized and you will not have much. But anyhow, you have done it. I don't know. Because I am seeing it purpose. Go ahead. Now the question here, she had a recurrent episodes due to ammonic encephalopathy. It is not primary metabolic disorders of ammonia cycle because she had 2 pregnancies and had a baby. Therefore, it is an acquired ammonia encephalopathy. The common cause of acquired ammonic encephalopathy is a chronic parenchymal liver disease with hepatic encephalopathy. But the picture is not suggestive of hepatic encephalopathy because under LFP functions and other things is a compensated liver. And there is a portal vein thrombosis with collaterals. I do say there is an extra hepatic portal vein thrombosis that is not converted, which is resulting in shunting. But usually, an extrahepatic portal vein thrombosis resulting in shunting will not cause ammonic encephalopathy unless there is a cause of communication of ammonia producing organ to the liver. That is kidney. The 2 episodes of unconsciousness are preceded by high nitrogenous non-vegetarian or vegetarian. That also
non-vegetarian.
That you have asked. Has she had a feast of non-vegetarian prior to that 2 to 3 times. Then the shunting will result in reversible ammonic. Why? A primary hepatic cirrhosis resulting in ammonic encephalopathy of 4 times of unconsciousness in hepatic coma, recovering on its own without much attrition and much things, and showing that the picture of collapse as well as these things is unlikely to live for that long time.
File was sent. Antithrombin 3. There is decreasing levels of antithrombin 3, that is 65%, normal is 83 to 128%. Protein C assay was done, which is 32%.
What is the difference of this? If this is consequentially a primary liver disease, or the primary liver disease hepatic is consequent to thrombotic primary abnormality, because that is a very important point. This is not this ordinary case. This should be kept for a senior component of gastroenterology panel discussion for you to get into the group of final diagnosis. It is not an episodic encephalopathy primary originating in the brain. Episodic encephalopathy is primary origin of primary ataxia is episodic encephalopathies and episodic amnesia. They are all primary neurological disease. But here there is no neurological. This is a primarily metabolic disease, secondary to a thrombotic episode in the portal vein, and portal vein resulting in renal anastomosis and circumventing ammonia metabolism from the liver to the systemic circulation. There is a very interesting case. The primary pathology is probably an extended spectrum of coagulopathy of APLA or acquired otherwise. Primary APLA because the area is big. And she had uneventful pregnancies. Second.
15, her GCS was 15/15, vitals were stable. Same treatment was continued except injection Clexane converted to tab Apixaban 5 mg BD after 14 days. Serum potassium was normal. Final diagnosis: episodic hepatic encephalopathy secondary to portal vein thrombosis, secondary to antithrombin 3 and protein C deficiency. During follow-up, she had no further episodes of encephalopathy. She is on tab.
Therefore, what is your advice for this man? Not Apixaban. Because it is what is the type of antithrombin deficiency, I don't give an Apixaban for that. We will only give a small amount of antiplatelet suffices, and the advice is to avoid to become gain or vegetarian. And prophylactic metronidazole forever, 500 milligrams for some time or 1 gram. And the best thing is surgery. Renal, but caval anastomosis. This is the best case for caval anastomosis.
What is the cause for liver disease?
Fatty infiltration.
What caused the portal vein thrombosis?
Is you do inherit.
She has only portal vein thrombosis. Portal vein, which is
eccentric vein as well as inferior cava.
portal vein.
Venous cells.
Portal vein and respiratory.
So she had hepatic vein also. It was SMV, no? Superior mesenteric vein going into the portal vein is draining to SMV going to portal vein, continuous thrombosis. Any other venous involvement? In the abdomen, non-venous segment involvement. Any arterial involvement?
No, sir.
Any episodes of any ischemic events, any abortions,
No,
nothing?
sir. No, sir.
What do you think the cause for protein C deficiency in this case?
What?
Protein C deficiency.
Yeah.
Cause, what is the
That's a primary or secondary, that's the question. Am I right?
It is the effect of the liver disease. The liver disease has caused the protein C deficiency. So it is not a primary protein C deficiency causing hypercholesterolemia liver disease causing this. The liver, there is something the portal vein is either a NCPF or NCPR thrombosis, which has involved the liver, which has extended to the SMV. Or is it a primary chronic liver disease? Here this itself can cause portal vein thrombosis. What happened to the spleen?
Spleen is normal.
So if spleen is normal, can it be a portal venous thrombosis?
Renal alignment is there. Here, what my contention is a primary vasculopathic disorder resulting in portal vein as well as other vein thrombosis, primary venous thrombosis, not secondary a primary hepatic disease.
I think it is not hypercholesterolemia stage. What happened to the spleen?
We are contention now. If you clarify.
If it is a portal vein thrombosis, spleen should be enlarged. And if you have SMV thrombosis also, SMV is going to portal vein, your splenic vein also should come and join something. Then she has a splenic to renal.
Wonderful questions. Now we'll come to it. If it is a primary hepatic disease, the INR should be high before there is reflected in terms of protein C and protein S. What is INR?
So is it
You have
NCPF?
to tell that. International decline of prothrombin factor is normal. It cannot have reflections in the secondary antithrombin levels.
Is it NCPF?
Liver biopsy will tell consequences of fibrosis. It doesn't tell it is a primary or secondary.
Portal vein pathology.
which has caused the liver disease.
Yes, sir. What is the commonest? We call that as Batten syndrome or primary glandular portal hypertension axis failure. But the spleen is not there.
The spleen is the most important. You have the venous collateral going from splenic vein up to the renal vein. Such a huge collateral is opened up, then why there is no spleen?
Yeah, she cannot answer. Now I'll tell you. If it is a primary portal vein thrombosis, which is very common in pediatric case group with bronchitis and other things, infection of particularly pericardial and pericardial as well as late onset. But here, an elderly middle age having a portal vein thrombosis with any amount of bronchosis or any other things, and it is not simply portal vein thrombosis. Why? It is extended into the superior inferior vein. Am I right? Superior vein.
Portal system, not in the systemic system. It is a portal venous system. Is it in the systemic venous system? It's only the portal venous system. Nothing on the systemic.
No venal, vena cava, abnormal.
Only portal system.
Yes, that's what makes me. Yeah, because spleen dysentery and portal vein is involved, and if it is a primarily due to a cirrhotic liver, then there should be coagulopathy, which should be reflected in ICM, INR, and
NCPF. Non-cirrhotic portal fibrosis.
Non-cirrhotic portal fibrosis will have collaterals, but not the thrombotic because it is a massive spleen. Often the massive spleen excludes non-cirrhotic portal fibrosis. Presence of portal vein and superior mesenteric vein thrombosis in the presence of abnormalities of the coagulum, that is antithrombin protein C proteinase. It is a primary coagulopathic disorder acquired. We have excluded SLE, but it is excluded, I think, for ANA2. Therefore, fortunately, it has come after pregnancy. Otherwise, you would have pregnancy. Therefore, it is a primary coagulopathy involving the portal venous system. Fortunately, the systemic vein of renal vein is patent, which is corroborated to the splenic vein, and ammonia has gone in. Not because of ammonia is being from the inability to convert to urea, from the primary liver dysfunction. In the primary liver dysfunction, ammonia is converted to urea. Whenever you take a lot of non-vegetarian, more ammonia, despite liver cannot convert ammonic encephalopathy as a systemic. But when the kidney and the liver-renal anastomosis, which can happen in primary cirrhosis also, can have ammonic encephalopathy if you do an anastomosis. But here, the anastomosis is done naturally, liver-renal, because for portal hypertension, liver-renal, linocaval anastomosis for the good olden days, surgeries of choice before the trap shunt and other things. And that makes a trans-tip procedure. Now, this fellow needs a tip procedure to divert the entire renal, that means splenic vein to that to prevent the
Splenic infarcts at all. Okay. There's no ischemia, but they might have
It's hepatic intervention of tips to convert the entire portal blood through bypassing so that ammonic encephalopathy doesn't occur and it will be filtered in the pulmonary circulation and so forth. He needs to have a account to exclude any pulmonary hypertension. Thank you. This case should be presented and it should be discussed further.
Sir, cause for hypokalemia. Cause for hypokalemia was present in 2 events before hypokalemia.
Hypokalemia. Hypokalemia.
Is it drug induced?
Can be due to secondary hypertension.
What? He was treated with diuretics?
No, sir. He was not treated.
What is the
Can be
age?
secondary due to secondary hyperaldosteronism, DC and D.
You have any ascites?
RAS activation.
Any ascites?
No.
Any edema? Albumin is normal.
There is no decompensation. So there is no ascites, there is no splenomegaly.
That's why it is extra. And
So what is the cause for hypokalemia?
Hepatic portal hypertension.
Even hypokalemia will precipitate the hepatic encephalopathy. It is a risk factor.
Yes, very good. One type of ammonic encephalopathy is not cirrhotic hyperencephalopathy.
That's why
That can only be precipitated by hypokalemia as well as blood in the gut, but not free. This will not have a metabolic consequence. Polyamorphic component.
Why hypokalemia?
Yeah?
Why hypokalemia?
You tell it. I will give the reason. Antivirus. Huh? Panel negative? Virus. Negative. Come on. Can you make any comments on the hypokalemia? What he says?
Hypokalemia, first we need to know acid-base status. Only if you know the acid-base status, we can comment on the potential. The patient has metabolic alkalosis, straight away it explains this.
ABG focus చేయాలి. Therefore, any amount of encephalopathy, the first component in the presentation is alkalosis or acidosis. If it is acidosis, alkalosis, they will have hypokalemia. If it is acidosis, they will be hypokalemia. ABG should be projected here. Okay. Sir, this is a very wonderful case. An adult onset of pulmonic encephalopathy unrelated to primary liver disease of cirrhosis, secondary to vascular thrombus, primarily coagulopathy acquired. That is a beautiful problem.
Dr. Saudia, Senior Assistant Cardiology. The session will be moderated by Dr. B. Sampath Kumar.
Good afternoon, everyone. This is a case of life-saving primary PCI. It's a case of 30-year-old male, chronic alcoholic smoker, came to ER with the chief complaint of chest pain since 2 hours, associated with sweating, shortness of breath, palpitation, abdominal discomfort and nausea since morning. History of present illness. Patient was apparently normal 2 hours prior to the presentation, then presented to ER with sudden onset central chest pain since 2 hours, retrosternal in location, radiating to upper back, associated with palpitation, sweating and not relieving with rest. Patient complained of abdominal discomfort associated with nausea, not relieving with medication, and there was no history of similar episodes in the past. Family history: father had coronary artery disease and PTCA was done. Drug history, not significant. Vitals: patient is conscious, coherent, and oriented. Pulse 92 beats per minute, regular in rhythm. With blood pressure 140/80 millimeters of mercury in both upper limbs. Respiratory rate 22 cycles per minute. No accessory muscle usage with saturation 98% at movement with GRBS 150 mg/dL. ECG at admission. This is fairly standard ECG showing. This is 12-lead standard ECG. It's showing ST elevations in. This is sinus rhythm with 1:1 conduction, and there is an ST elevation from V2 to V6 which shows LAD occlusion along with the 1 and aerial ST elevation. 2D echo shows RWM in LAD territory with EF of 45%. There is mild LV dysfunction with trivial MR here, grade 1 LVDT with no AR, PAH and normal IVC. This is a chest X-ray of
This is a frontal chest radiograph with trachea in midline, apparent cardiomegaly due to mid-inspiratory swelling, mild prominence of bronchovascular markings seen, rest of the bilateral lung fields appear clear, bilateral coastophrenic angles are free, both domes of diaphragm are bilateral.
So we came to the diagnosis of coronary artery disease, that is acute anterolateral wall MI with mild LV dysfunction, normal sinus rhythm and not in congestive heart failure. Clinical course in hospital. Patient presented to ER at 10:30 AM and diagnosed with acute anterolateral wall MI and loading doses were given. Patient was shifted to cardiac ICU within 20 minutes for monitoring and observation. As the cath lab was occupied, they were waiting for lab report and the plan was primary PCI. Timeline of events. Patient developed ventricular tachycardia and was unresponsive. Immediately DC shock of 150 drops were given and patient reverted to normal sinus rhythm. Recurrent VT episodes occurred at 5-minute interval with a total of 3 episodes of hemodynamically unstable VT. Each episode required DC cardioversion with 150 drops, 200 and 200 drops respectively. Successful restoration to the normal sinus rhythm each time. So emergency CH and primary PCI was done. These are the blood investigations which showed WBC count 25,000 which is expected in acute MI and ROT positive, that is 159. And lipid profile showed triglyceride levels of 237 and LDL of 110 with the elevated AST and ALT, that is 761 and 180 units. As patient complained of abdominal discomfort, we wanted to rule out the pancreatitis, so even the enzymes were normal. Red blood and creatinine were normal. This shows the coronary angiogram of LAD territory showing this is a coronary angiogram of LAD territory showing LAD thrombotic occlusion in the proximal LAD, and this is a coronary angiogram of right coronary artery which is normal. And this is the primary PCI to LAD. There is a stent between these two dots, and there is we are doing the balloon dilation. We have taken a sirolimus drug-eluting stent of size 3 into 32 mm, and this is the last shot, that is kidney free flow established in the LAD. After PCI, patient was shifted to CSU for 48 hours for observation, and tirofiban infusion was given for 12 hours, and patient didn't develop any episodes of ET or BR. So patient was discharged in stable condition with medications and advised lifestyle medication and lifestyle modification and drug compliance, and reviewed after 1 weekly follow-up. The discussion: myocardial infarction in young age is rare, and our patient is 30-year-old, presented with classic signs of anterior STEMI without prompt defibrillation. Outcomes are often little. So what saved this patient is actually time, shock, and stent. Coronary artery occlusion in the proximal LAD, the so-called widowmaker, doesn't always give a second chance. So take-home points are: immediate DC cardioversion is life-saving in hemodynamically unstable VT, and in unstable rhythm, treatment should not be delayed for BP confirmation. Rapid rhythm recognition and shock delivery resulted in successful neurological recovery in this patient, and in this patient, recurrent VT resolved after PCI to LAD shows that ventricular arrhythmias were ischemia driven, and PCI was the definitive treatment. Interestingly, the intervention coincided with the patient's birthday, marking not just another year but also second chance at life. And from the Department of Cardiology, we have given a gift, that is STEM, and that's how a 30-year-old walked out alive from our front.
I was not there at all, but they took care very efficiently, and very good work done by Shaudra and all the team members that did. So actually, primary PTCI will help the patient to actually some of the patients who have this patient had recurrent VT, shock was given, reward, then for primary, and then before they are ready to the young man, so in the rule and LAD block, straight away it will be done, and if there are, sometimes we have multiple blocks, then it will be difficult and a lot of other problems will be there. But whenever an acute MI is there, now the present trend all over the world, even in India, many places, the people started doing the primary PTCA, and it helps. And see, even Telangana government, the deducted place is also given to all the patients who have fishing. And one more thing is, deducted place is in our hospital only given to neurology, and not giving it to the cardiology. So I request the administration see that deducted place is also given to the cardiology department for acute MI, so that patient will benefit. And the only advantage is deducted place is given in the casualty itself, so that action will be good. It's just given intravenous injection, not like drip with the streptokinase or other thrombolytic agents like that. So that's the only request, so that, and see, for hospital, MRP price is different, but hospital will get for 10,000-15,000, and which is not, and also is covered under the acute MI patients. They give 25,000 for treating acute MI patients. So definitely that's cost effective also. No, I won't say that all patients who are eligible will give it. But some patient who come later definitely will go for streptococcal.
Is that the slogan that every case which comes in the golden window to have attempted of a primary PCI?
Now that is the trend like that.
Not trend. The visa versa, what are the outcomes of which have been established in the last 2 decades?
Primary PCI
nearly started 20 years back.
That's what I'm not asking. Not sir, reverse. The resident should answer. Primary PCI, which should be done in all institutes equipped with cardiac lab, but not thrombolysis. Thrombolysis is what is called delegated to the peripheral taluk and other hospitals. PCI is the cornerstone for the teaching hospitals. And what is the quantum of your PCI? What is the quantum of thrombolysis?
See, if the patient, whoever the patient comes, he comes in that hour, like less than 12 hours, we take for PCI. So only patient, but here our rural people, they are ignorant, and many of them, they don't see the doctors, and they see the family doctor or the RMP physician. He says it's acidity, all those things, and then they come late. So then sometimes we will not be able to do even thrombolysis also. Then we take them for angiogram and do angioplasty. And sometimes few months back myself, I was taking classes in the NIMS for cardiology students. And that Somaran was also by my side. Myself, Somaran is Krishnamran was the panel. Then he said, Sampan, if you are not doing primary angioplasties, that's the only thing which will help the patient. Routine angioplasties will help to some extent, but not a tremendous relief as you get in a primary angioplasty. So like this patient, who had a recurrent VT, shock was given, and then they... And
Professor has pointed out, sir, you have made a point of a question. Primary PCI will have an enormous amount of advantage rather than other secondary components. What is the reason?
Distribution of the coronary blood flow is the primary.
No, nature of thrombus.
And also the muscle is preserved, so every function will be preserved, and long-term survival and all those things will increase. Once you have an attack and they come after 12 hours or 24 hours, muscle is damaged. Even if you do angioplasty, some benefit is there, but not the real benefit as you get in a primary angioplasty. And actually, I have to say that a good thing is Dr. Venu was there as assistant professor here for 3 years. He was doing, and now he in a Jaggareddy in a small place. He has his own cath lab, and he has done, sir, I have done some 7 patients of acute angioplasty primary, he said. Only it was the training I got in Pinnamaneni and your guidance like that. And I said, I appreciate Venu, seen a primary place where there are no other supporting people like other cardiologists, other things, taking them up, and also I'm charging only obviously like 60,000 or 70,000, no extra money like that. And really, you continue that, but little careful. Don't be very aggressive. Sometimes if something happens, the people will say the doctor has done this, all those things. So in that way, and many of our people got trained from here, they are doing primaries.
Presentation is a pattern rash with predictable evolution, presented by Dr. Geetika, Junior Resident, Department of General Medicine. Session will be moderated by Dr. B. Sujateja, Assistant Professor, General Medicine.
Today, interesting case regarding the pattern rash with predictable evolution. A 51 years old female present to our tertiary care center with the complaints of generalized skin rash involving the trunk and proximal limbs, associated itching and burning sensation, and peeling of palms and soles. History of presenting illness. The patient was apparently asymptomatic until she noticed a single, well-defined, hyperpigmented, scaly raised lesion which appeared initially over the trunk. This lesion was followed after a short interval by a sudden onset of multiple small lesions distributed predominantly over the trunk, abdomen, proximal limbs, and genital regions. The subsequent lesions were described as hyperpigmented to reddish discolored, scaly lesions associated with mild to moderate pruritus and burning sensation.
Over the course of illness, the patient also noticed peeling of the palms and soles without fissuring, bleeding or ulceration. Importantly, the rash has a centrifugal spread predominantly involving the truncal region, relatively sparing the face, and there is no history of photosensitivity or absence of mucosal erosions or ulcerations. There was no history of fever, malaise, upper respiratory tract infections, sore throat, arthralgias, myalgias, vomitings, or loose stools. The patient denied recent intake of any new medications, including NSAIDs, antibiotics, herbal preparations, or antiepileptics, prolonged sweating, occlusive clothing, or contact with the infected individuals, history of nocturnal itching, or involvement of close contacts. Past medical history. The patient is a known case of type 2 diabetic mellitus since 12 years on tablet glimepiride metformin 3 by 1000 mg twice daily and dapagliflozin plus sitagliptin 10 by 100 once daily in the afternoon, and known case of hypertension since 6 years on Telma H once daily. There was no history of bronchial asthma, epilepsy, tuberculosis, autoimmune disease, or chronic dermatological illness. She had similar lesions in the past 8 months on and off, for which she was treated by a local doctor with topical betamethasone or momentosone creams, where there is no symptomatic improvement was given. And patient refused of taking any systemic therapy with oral or intramuscular steroids. Gynecologically, she attained menopause 5 years ago. No history suggesting of pregnancy-related dermatosis or hormonal exaggerations. Personal history, appetite and sleep were normal. No history of tobacco, alcohol or substance abuse. No occupational exposure to chemicals or irritants. On general physical examination, patient was conscious, coherent and cooperative and well nourished. Afebrate with pulse 78 beats per minute, blood pressure 110 on 70 mmHg, respiratory rate 18 cycles per minute. There was no pallor, icterus, cyanosis, clubbing, feeder edema or generalized lymphadenopathy noted. These were the lesions showing a peeling of the first picture showing the peeling of soles and palms. The lesions, white flaky lesions on thighs. On systemic exam.
As you can see, the first picture, discoloration with peeling noted over the entire soles. And second, candidiasis with white other end, curdy white discharge or genitals, with erythematous scaly plaques and papules, and erythematous papules noted over abdomen with the scaling noted. And there are multiple erythematous papules with peripheral scaling noted over some, and fewer hyperpigmented papules with various thighs noted.
At the end of this inspector lesions, as a resident, what is your differential analysis?
It is acute papules eruptions.
Papule eruption is not differential analysis.
Okay.
They are all descriptions. Don't give
Pityriasis rose.
Okay. What diseases should you put as differential diagnosis in that picture at this point of time? Are you eligible to ask this question, answer, no, madam? As a resident, you answer it.
First, differential is pityriasis rosea. Second is pityriasis lichenoides chronica. And as she used some topical steroids for 8 months.
After the lesion, she has used it, but not before.
Okay.
Therefore, it is not incriminating. Anything else? Third
Can
one?
be psoriasis.
What type of psoriasis?
Guttate psoriasis. Because lesions are small drop-like lesions, so it can be a guttate psoriasis.
Comments from your side. Your resident is eligible for pass or distinction.
Sir, actually, chronic plaque psoriasis could be a least possible, sir, which is modified by application of steroids. Could be a possibility, but it's not classical. Could be psoriasiform dermatitis. Dermatitis, which is mimicking psoriasis, is a better definition compared to psoriasis.
Like
Psoriasis like dermatitis. Most probably, sir. Or a psoriasis which has been modified by repeated applications.
Any more dimension? Any more than other dimensions like to make in this?
In the chronic picture, probably on the trunk and genitalia, the lesions have been started. It could have been a primary ACD also, sir, which has been disseminated now. Allergic contact dermatitis could be a possibility.
Wonderful. There are now 4 different diagnoses and your resident will chart it out at the end. Perhaps it doesn't much help. It is only a descriptive form of dermatology.
Cardiovascular system shows normal S1, S2 and no murmurs. Respiratory system shows clear lung fields. Abdomen soft, non-tender, no organomegaly. Central nervous system has no focal neurological deficiency. Dermatological examination shows cutaneous, multiple discrete to confluent erythematous and hyperpigmented plaques. Lesions exhibit fine peripheral colorate scaling. Distribution was predominantly over the trunk, abdomen, proximal limbs and genital regions. Palms and soles showed peeling without erythema, vesiculation or fissuring. These are the lesions on the back showing maybe Christmas pattern, not
This may help your both diagnosis of this component. To think it but to exclude.
In psoriasiform is a better descriptive term, sir. Christmas tree is not there here. That's what.
But the edges are showing.
Yeah, edges are showing just colored scales. That's it. There is no Christmas tree.
There were no silvery scales, annular lesions with central clearing, no hypopigmented macules with fine barney scales attenuated on scratching, no burrows or exfoliations, no mucosal involvement. Her CBP on day 1 is HP 11.8 gram per year, WBC 17,400 cells, neutrophils 60, lymphocytes 27, eosinophils 7, basophils 0. Platelets were 4,46,000 and NCB value is 65.4, NCHC is 29.9 gram per year, PCV is 39.4%, with WBC, total WBC is 4.19 million, in ESR 134 mm. With impression normocytic, with peripheral smear impression, normocytic normochromic, microcytic hypochromic, with the dimorphic anemia with leukocytosis. Her RFT is urea over 43 mg per dl and creat is 0.7 mg per dl. Serum electrolytes sodium 136 milliequivalents per liter.
Everything is normal except the uncontrolled diabetes.
And HbA1c level is normal.
CRP is right, incommensurate with the ESR. Explain that.
Her lipid profiles, LFTs were normal. Her lipid profiles are total cholesterol 230, showing dyslipidemia, and FBS is 256 mg per dl and PPBS is 371 mg per dl. Her CUE is normal with WBC count 61, high power. So our provisional diagnosis may be acute papillomatous eruption with may be due to pityriasis rosea, steroid-induced tinea, gutted psoriasis, pityriasis lichenoides. It's chronic uncontrolled type 2 diabetes mellitus with hypertension. Treatment given on the first day is IV fluids, 12th RV, tablet linezolid 600 mg per oral, 12th RV, with injection human act rapid of 22, 20 and 16 units in the morning, afternoon and night respectively. Injection Basilog at 10 p.m. subcutaneous 20 units with Telma H, OD and fluconazole 150 mg once weekly for 4 weeks with tablet Levoshine 5 mg per hour in night and moisturizer. Chest X-ray showing.
This is a frontal chest radiograph with trachea and midline. Cardiac shadow appears to be mildly enlarged. Bilateral lung fields appear clear. Bilateral costophrenic angles are free. Both domes of diaphragm are well apparent.
For ECG, 12-leaded ECG showing normal sinus rhythm. 2D echo was normal. Normal LV function with EF 60%. And there are no sonological abnormalities in ultrasound. CPP values on day 2 to day 6, the counts are in same trend. Extract. Dermatology referral was taken. They advised a tablet Omna Cortil 20 mg OD for 5 days and tapering doses. To continue moisturize soap with Moment Cream local application, tablet Fexofenadine and fluconazole 150 mg once weekly for 4 weeks. Ophthalmology referral was taken. Fundus revealed both eye senile immature cortical cataract with left eye dry age-related macular degeneration and no evidence of diabetic retinopathy. Treatment given from day 2 to day 6 continued tablet
cream added antifungal cream.
Yes.
Your biopsies are mention the site of the biopsy.
Left medial aspect of lateral forearm.
Show this here now. DBS. Yes. Comments?
This is the focused photo micrograph of HLV stain section showing skin line by keratinous stud squamous epithelium with hyperkeratosis, confluent parakeratosis. There is mild keratosis with focal necrotic keratinocytes and exocytosis of the lymphocytes. This is the high power view showing focal areas of neutrophils in the stratum corneum and mild macular degeneration in the basal layer. This is the low power view showing perivascular superficial W showing perivascular lymphocytic infiltration. These all pictures are in the favor of pityriasis rosea.
This is the biopsy report, sir. Histological features are in favor of pityriasis rosea. After 10 days of therapy, the patient improved. The peeling and on discharge medication, injection human mixture 50 by 50 or 40 units and 38 units were given with tablet Histamet 50 by 500 mg per oral BD and tablet Obligos 0.2 mg per oral BD with fluconazole 150 mg once a week for continuing for the 5 weeks and phenoxycyclate rosuvastatin was added. So final diagnosis is pityriasis rosea secondary to chronic uncontrolled type 2 diabetic mellitus and hypertension.
So ma'am, is there any relation as sir has rightly asked to this uncontrolled status of diabetes or anything related to the topical steroid creams which are prescribed by the local practitioner?
So first, pityriasis rosea doesn't long for that duration, 8 months, so I'm not convinced with the diagnosis.
There is absolutely any relation or absolutely no relation to the diabetes control. That's the question.
No, sir. Pityriasis rosea is usually HHV7 induced immunological phenomena. Rarely, sometimes due to some vaccines or certain GI infections, but diabetes, yeah.
It is a self-limiting condition.
It's just a immunological reactive pattern. Usually lasting for 1 to 2 months.
Suppose if she has come very early in the part of the first steroid patch of something up like that in the first 1 week, do you like to give any specific treatment of antiviral nature?
For these patients?
Yeah.
Usually only symptomatic treatment, sir.
No antiviral to precipitate to prevent further relations.
It's only symptomatic, sir. If it is very severe, it is interfering with quality of life, very low dose steroids we do consider.
What?
Low dose steroids we consider. We try to find out any primary first.
No, my question is antivirals.
Antivirals generally, but P-rosea we don't give, sir.
You used to give?
We used to give, sir. Yes, previously Aceclava used to be given.
No, nowadays study is there, but not now. Yes. And now, therefore, it is a coincidental thing. Therefore, diagnosis is pityriasis rosea and uncontrolled diabetes.
And
be a better.
And
the second thing for the TCI.
And I think PLC.
The question is, uncontrolled diabetes can it worsen the relapsing nature of pityriasis rosea? Any literature?
Sir, as I told you, it's a trigger by some antigen. It doesn't. I don't think diabetes will influence that.
Got some comments?
I think uncontrolled type 2 diabetes itself is a quite immunosuppressive kind of illness, so it could have.
Therefore, diabetes per se is an immunosuppressive stage of metabolic nature, which can aggravate. Support of literature. You cannot accept what the conjunctional corroboration. You have to have a literary component of academic evidence.
We can't always say that diabetes suppresses immunity, so there should not be any allergic reactions. We can't say that.
Any literature from your side? You have got so plenty of question number 1. There are so plenty of diabetic population. Almost 1 out of 3 are diabetic, and 2 out of the 4 diabetics will have some dermal problem. How much of pityriasis rosea you see in diabetes vis-a-vis non-diabetic? Has any component of analysis is done in your department?
Mostly in the middle age group and adolescent we see commonly, sir. Diabetes I don't see much relation.
My question is, has it been done? Either somewhere
we didn't
or
do
here.
any studies, sir. I'll just go to the literature also.
Therefore, I will give that exercise to you to make answer for your president. We'll stop at this point. Next, last case.
Lines are very good.
Yes, could be there.
Pellagra, presented by
Don't
Dr.
say anything Allegra, let them make it. Otherwise, you will give Allegra.
Presented by Dr. Y.M.M. Ganesh, Junior Assistant General Medicine, Moderator Dr. Anaga Devi, Assistant Professor Medicine.
Third year junior resident from Department of General Medicine, and my moderator is Dr. Anaga Devi ma'am, Assistant Professor. Today I am presenting a case of 50-year-old male who is a chronic alcoholic and vagabond with poor nutritional status, present to our hospital with complaint of rash and itching all over the body since 2 years, generalized fatigue since 3 months, loose stool since 2 months, altered behavior and irritability since 2 months. Patient was apparently asymptomatic 2 years back. Later patient developed rash with itching all over the body since 2 years, insidious in onset and gradually progressive, predominantly involving forearm, neck, associated with pruritus, later progressed to all over the body. No history of vesicles, discharge or bleeding. Poor response to local treatment was noted and the medications were not known. Complaints of generalized fatigue since 3 months, gradual onset, progressive in nature, present throughout the day, not relieved by rest, associated with reduced appetite, weight loss and decreased work capacity. History of loose stools since 2 months, 3 to 4 episodes per day, yellowish, watery in consistency, small volume, no blood or mucus, no associated abdominal pain, vomiting, fever or tenesmus. No history of recent travel with intake of outside food present. Complaint of multiple falls since 4 days. History of altered behavior and irritability since 2 days. No history of loss of consciousness, seizures or focal neurological deficits. No history of fever, jaundice, abdominal pain, marina, hematochezia. No recent infections or contact history. No seizures or focal deficits. No vesiculobulbous lesions. No drug history causing photosensitivity. No similar illness in contacts. Past history, history of query seasonal cirrhosis and treated at local hospitals from 4 years. Is a chronic alcoholic, taking 110 grams per day. Last binge was 5 days before admission, and he is a chronic smoker with 30 pack years. Known asthmatic at childhood, not a known diabetic, hypertensive or other disorders. Occasional use of diuretics was present for pedal edema. Before joining in our hospital, he had 2 units of packed red blood cells. On general examination, patient is poorly nourished with signs of pallor and dehydration. This image showing beefy red tongue with angular cheilitis. There is symmetrical hyperpigmented lesions involving hands and feet, exfoliation with underlying hyperpigmentation with few excoriations with crusting over finger web spaces, erythematous to skin colored scaly plaques with fissuring noted over left anterior cubital fossa. These are other images showing hyperpigmentation. This image showing
to describe any other resident, not only you, there are so many. Take the European vesicular chain lesions. ఎవరొకరు నువ్వు నీకు ఇక్కడ ముందే కంటే ట్రైన్ వెళ్ళిపోతుంది
Hyperpigmented scaly plaques noted over dorsum of bilateral hands, and hyperpigmented scaly plaques and featuring or xerosis noted over back. There is hyperpigmented scaly plaques with fissuring noted over cubital fossa, and hyperpigmented scaly plaque with fissuring noted over lower end of the left leg.
Go back to the abdominal and hand.
Xerosis noted over back with exfoliation with underlying hypopigmentation noted over back. Over bilateral hands, dorsal aspect, we can see hyperpigmented plaques with fissuring. And underlying hypopigmentation is also present.
Due to unhealthy and not taking too many any bath for the last so many years, the anterior abdomen and this are really unrelated to his status of hygiene.
For that we have to.
You have asked the history. For that,
patient is alcoholic and these lesions are mainly over sun.
What I am interested in that is, can you call that hyperpigmented with hypopigmented late lattice-like preparation any crazy pigment word can be used or not? That's my question.
No, sir.
Why? Either in the hand or in the one of the two. Three.
Because the lesions are very thick and block-like.
Huh?
Lesions on the hands are thick and on the back.
On the abdomen? Unexposed area? Okay.
So for that we have to demonstrate with using a spirit so that if it is a terriform format we have to demonstrate it, otherwise.
My question is only inspective finding.
No, sir.
Dark scale pigmentation is not in a regular horizon of things, it is irregular. The irregularities can be called as crazy. That is the only question. This irregularity of hyperpigmentation with islands can be called as crazy. Word, that's all, nothing else. What is the different language will come in later. But not this. I am not concerned with the second two photographs where there is hypertrophy and all these things. That's the difference.
Patient's vital showing tachycardia and tachypnea. On systemic examination, GCS was 13, that is E3, V4, M6, and patient was drowsy at the time of examination. Tone and power was decreased, all 4 limbs. Cerebellar examination cannot be done at the time of assessment. Other system examinations were normal. Our provisional diagnosis was metabolic encephalopathy and chronic malnutrition with alcohol use disorder with alcoholic liver disease with dermatitis very nutritional. Differential diagnosis was pellagra secondary to alcoholism and alcoholic liver disease, and other DDs were photosensitive dermatitis secondary to SLE, porphyria cutanea tarda, and chronic arsenic toxicity. This is the 12-lead standardized ECG showing normal sinus rhythm. Chest X-ray.
This is a frontal chest radiograph with trachea in midline. Cardiac shadow appears to be normal. Aortic knuckle calcification seen. Bilateral lung fields appear clear. Bilateral costophrenic angles are free. Both domes of diaphragm are well outlined.
2D echo, suboptimal echo window with showing tachycardia. Investigations in our hospital was normal, only with raised MCV. LFT showing mild transaminitis with hypoalbuminemia. TSH profile was normal and creatinine was elevated secondary to dehydration. Sodium and potassium were decreased with decreased vitamin B12 level, and the virals were negative. D normal. ABG at the day of admission showing metabolic alkalosis. Ultrasound revealed dilated cystic duct and proximal CBD to rule out mid or distal CBD obstruction. Upper GI endoscopy was done in myope dysphasia, showed Mallory stare with multiple gastroduodenal ulcers. Serum gastrin levels were sent to rule out Zollinger-Ellison syndrome, which was normal. Dermatology referral was taken, kept the provisional diagnosis of. On examination, trunk exfoliation noted over back and abdomen with underlying hypopigmentation, exfoliation with underlying hypopigmentation and few excoriations noted over dorsum of both hands, excoriations and crusting noted over finger web spaces. Erythematous to skin-colored scaly plaques with fissuring noted over bilateral cubital fossa. Skin-colored to hyperpigmented plaques with fissuring noted over dorsum of both feet. Exfoliation over erythematous background with few fissures noted over both legs. Exfoliation over bilateral thighs and few erosions over buttocks or pubic areas and bilateral groin and scrotum. In oral cavity, erythema with loss of papillae noted over tongue. Angular cheilitis present, nails showing longitudinal ridging.
What is the inferential value of clinical of the nail longitudinal ridging? No inferential value or generalized or a focal inference? Comments? Because there are so many features in the nails, what is the inferential value of longitudinal ridging?
It's seen in so many conditions, sir, nothing specific.
That is, focal inference is not there, only generalized.
Yes.
Generalized, it tells anything?
You mean longitudinal ridging, sir?
It tells you chronic illness or chronic malnutrition, nothing.
Nothing specific, sir, but something we are dealing with chronic, at least it gives that information.
Is it related to the turnover of the nail abnormality? Longitudinal ridges? Vice versa, horizontal lines?
Not turnover, sir. Sometimes repeated scratching. He was not even maintaining.
You are not sure the nail. Because it is brittle with longitudinal ridges and non-brittle with longitudinal ridges. That's my question of that.
Provisional diagnosis was atopic dermatitis or dermatitis secondary to nutritional deficiency or chronic irritant dermatitis.
A wonderful point is raised here, think. Is it the zinc deficiency related dermatitis? President. Acrodermatitis, because you raised the issue of zinc deficiency. Is it what type of zinc deficiency dermatitis? Is it a neonatal or a pediatric or an adult onset? Liberated question there, madam?
It's adult.
Yeah.
Adult onset.
Zinc deficiency, you made a diagnosis. I am very much appreciative of that. If so, what is that called in clinical?
In case of pediatrics, we call it as acrodermatitis enteropathica, sir.
And that invariably specifically such as something else in addition to zinc. Okay. Now in the adult it is unlikely.
Yeah, it's
very rare.
nutritional deficiency.
Yeah.
Advised tabulast.
I am appreciative of your adding of the zinc deficiency, but in adults, a zinc deficiency is a very rarity. Let's see, without other divalent metallic ions.
Advised tabulast 20 mg OD and liquid paraffin topical application, fusidic acid cream over erosions and fissures. This is the history.
This is a focused photomicrograph. Actually, we received a 4 mm punch biopsy taken from the right side of the abdomen. So this is a focused photomicrograph of a H&D stain section in low power, showing skin with epidermis lined by keratinized stratified squamous epithelium, and striatum corneum showing here nuclear debris along with neutrophils. And here we could see marked spongiosis with few necrotic keratinocytes. Next. And here we could see perivascular inflammatory infiltrate along with dermal edema and few scattered eosinophils and some extravasation of RBCs. So all these features are in favor of irritant contact dermatitis.
Anything about the vessels?
Perivascular inflammatory infiltrate is there, sir, within the dermis, and the extravasation of RBCs are also there here.
Final diagnosis was primary pellagra due to chronic alcoholism, protein calorie malnutrition.
Pellagra. Because he is eating, primary pellagra is a deficiency of taking intake. Whereas he takes normal diet, but still is conditioned because of alcoholism.
Is not taking.
There is a little difference. Primary deficiency of vitamin, secondary deficiency of vitamin, and conditioned deficiency of vitamin. There are three varieties of things for all vitamins. A primary is not intake because of a polished rice and all these things. But otherwise, two is taking the things, but there is something metabolic error of the vitamin due to overuse by some other thing, or it is not being properly converted in the presence of alcohol and other things, or cirrhotic things.
Yes, sir.
And tumors, and giving rise to use of certain amino acids, and then giving rise, that is called conditioned deficiency.
Yes.
Therefore, all vitamin B complex deficiencies can belong to any of these three: primary, secondary, and conditioned.
Yes, sir.
And now, ever your histology is not in power, histology is showing something else. Comments of the histology with reference to your diagnosis and ours. And later, what is the follow-up?
Histology is showing classic dermatitis pattern, spongiosis, hypoplasia, some chronic dermatitis features.
Because there is no specific pattern for pellagra. The only component I would have been appreciated if you commented the pathologist on the vascular component and whether there is any neoangiogenesis and a dilated vessels. But there is vessel leak. That is not a specific thing. It can occur in inflammation, it can occur in condition, any deficiency also. Chronic dermatitis, nothing else. Go ahead.
Patient was treated with IV fluids and multivitamin injections for 100 mg 300 mg TID for 5 days and followed by OD for 10 days. And protein powder was given for 3 times a day. managed with nicotinamide supplementation, high protein balanced diet, sun protection and multivitamin therapy. These were the clinical pictures before and after treatment of 3 weeks duration.
Wonderful pictures.
There was rapid improvement in diarrhea, lesions regressed, behavioral symptoms improved, and typical dramatic response.
The story didn't end there. Okay, go ahead. Ask. Last.
Pellagra is a preventable and treatable disease. Always assess nutritional history in liver disease patients. Timely niacin therapy leads to rapid.
Always assess nutritional history. In addition, always assess whether he is a chronic alcoholic or not. That's the question comes out that alcohol can precipitate niacin deficiency. That's the question. Next, go ahead. What happened to him at the end?
He died after 1 month after discharge. At home also.
Therefore, his dog tail has become normal again. Curved. He went and went home and started re-drinking and ultimately died. The 4th D has come for the things. Therefore, he had a dementia, dermatitis, diarrhea,
dementia,
and altered sensory dementia, and everything calmed down. And again, 2 months, he went back and died. The 4th D embraced.
Nutrition should be.
What is the relation of alcohol to the niacin metabolism? That's the question. Like to comment? Or is this a general medicine question? I don't like to answer. You cannot say like that.
In chronic alcoholism, there will be B vitamin deficiency, sir. B vitamin deficiency will be there.
Why? That is my question. Deficiency. Why? Is it more utilization for alcohol metabolism vitamins, or more vitamin is available but there is a block in the metabolism of vitamin, or the vitamin is unable to act because of certain blocks in the alcohol related thing? That's the question here. And you must know that. Because one of the commonest causes in the present era is chronic alcohol, neglected, not seen. Isolated fellow, drinking, no food, nothing malsure. These are all the things come. It's a part of encephalopathy of Wernicke's, but niacin type of it. In which there will be B1 deficiency also. That's a common. Now, why a word is used here? You all know, for all your foodstuff, carbohydrate and protein converted to calories by burning them in the mitochondria by acetate, whether it is a carbohydrate or a fatty acid or a protein. Then it will be done at this point by NADP, that is nicotine adenine dinucleotide, nicotine adenine dinucleotide hydrolase, that is NADP and NADH ratio, which determines the quantum of energy in the mitochondria to be converted into the heat or to the ATP. Therefore, in the alcohol, the NADP-NA ratio will be altered in such a way that the energy produced will not be converted into ADP to ATP bonds as stored phosphorylation. All chronic alcoholics will have a dephosphorylation of the energy, which will become heat. The heat bonds and makes more amount of requirements of everything, and he loses. Even though alcohol is calorically about 7.5 calories per 100 grams of alcohol, those alcohol calories doesn't come into your ATP phosphorylation and energy phosphorylation. That's why it is called empty calories or spent calories, which will burn by producing more heat, decoupling. That's why alcoholics will lose protein, mass and everything, and atypical, ectopic fatty compound like pyrotics. Therefore, they have more calories, but they burn themselves. But the calories are not utilized as ATP, not converted. Therefore, everything is disarray, including nerve conduction as well as elements. And therefore, the requirements of all vitamins will be burnt out. And therefore, you will have a huge conditional deficiency also. Unless supported by other, good night.